Hello, everyone. Welcome to the University of Toronto Joint Centre for Bioethics Seminar Series. I'm Andrea Bianchi, and I'll be the moderator for today's session. Our speakers are Seth Climans and Caroline Variath, and this seminar is entitled Medical Assistance in Dying for Patients Diagnosed with Brain Cancer, a Global Perspective with Implications for Equitable Access. Before I introduce today's speakers, I'd like to let you know that the seminar is being recorded. This lecture, along with other archived lectures, can be accessed through the Joint Centre for Bioethics website. The format of our seminar is a presentation by our speakers, followed by a facilitated discussion period. We wish to acknowledge this land on which the University of Toronto operates. For thousands of years, it has been the traditional land of the Huron-Wendat, the Seneca, and the Mississaugas of the Credit. Today, this meeting place is still home to many Indigenous people from across Turtle Island, and we are grateful to have the opportunity to work on this land. Now, it's my pleasure to introduce today's speakers. Seth Climans is a neurologist. He completed his neuro-oncology fellowship training with Warren Mason in Toronto in June 2021. He is now an assistant professor at Western University, where he practices as a neuro-oncologist. Caroline Variath is a PhD candidate in nursing with a collaborative specialization in bioethics at the University of Toronto. She is also a faculty member at the Department of Health Sciences and Wellness at Humber College. So with that, I'll pass it over to our presenters, and I hope you enjoy. Seth, you can take it away.
Thank you very much. Thanks for having us here. We're excited to share with all of you the results of our research project. So, we're going to be talking about a research project that started a few years ago now at the beginning of my neuro-oncology fellowship. We thankfully were able to get funding through the GIPPEC grant, and we're grateful for that because this project would not have been possible without that. I have no disclosures. I'll just introduce you to our research team. So I was a neuro-oncology fellow in Toronto, Princess Margaret, when this started. I reached out to Jennifer Bell, bioethicist at Princess Margaret, also involved one of our neuropsychologists, my supervisor, Warren Mason, and then Carolyn became involved for the qualitative research. So I want to start out by giving you an anonymized illustrative case. I'll then talk about the background of medical assistance in dying in patients with brain cancer and the specific aspects of brain tumors, and how that might affect capacity and determinations of eligibility. We'll then talk about the project and the research endeavor that we went through, specifically a two-part project involving both surveys sent out to neuro-oncology clinicians all over the world, followed by interviews with neuro-oncology clinicians from around the world. We'll go over some of those results. I'll mostly focus on the results from the surveys, and Carolyn will then talk about the results from the interviews. So hopefully by the end of this talk, you'll appreciate some of the legal landscape for MAiD in Canada and elsewhere. You'll recognize some clinical factors that might signal impaired mental capacity around end-of-life decisions in brain cancer patients, and understand some of the reasons why neuro-oncology clinicians might or might not support a given patient's decision to have MAiD. So, I saw a 57-year-old woman in clinic, and she had developed focal seizures with loss of awareness in 2018, and then went to the hospital. She developed something called non-convulsive status epilepticus, basically really bad seizures, and had to be placed in the intensive care unit. While she was there, brain imaging was obtained, and this is what it looked like. There's a tumor in the anterior left temporal lobe. Notably, she was right-handed, and so language function tends to be in the left hemisphere. She underwent surgery, and it turned out to be, this is a rim-enhancing lesion within the left temporal lobe. After surgery, this turned out to be a glioblastoma, and she was treated with standard therapy. But after 7 cycles, she developed both clinical and radiological worsening and was switched to second-line therapy, which is then lomustine. A worsening again of aphasia and hemiparesis. So then she was put on a third-line therapy, which is a drug called bevacizumab. And I began collaborating with her family doctor at this point in the management of her chemotherapy in the community. And as I was talking, so I'll show you some of the imaging. This is what it looked like at first, after resection, and then the tumor just started growing. You can see it, a lesion there, growing, nodular enhancement, progressive tumor, getting worse and worse approximately every 2 or 3 months. And now you can see edema and tumor infiltration throughout most of the left hemisphere, especially the left temporal lobe. Notably, these are areas of the brain that control a lot of language function. And so I received a phone call from the family doctor about this patient, mentioning that the patient had requested medical assistance in dying. And I hadn't seen her in a few months, to be honest. I hadn't seen this patient in a few months, but I could see the MRI scans, and I was personally concerned that her language function was such that she would not be able to understand the conversation, would have receptive aphasia, had difficulties really consenting to this decision. The family doctor believed that she was able to consent, and she ultimately did undergo medical assistance in dying. But this whole patient scenario gave me an idea, which was, how do we assess capacity for an important decision like MAiD in our patients with brain cancer, especially if they have receptive language dysfunction? I asked some of my colleagues, and nobody had a good answer for how to assess this and how to determine MAiD eligibility for our brain tumor patients. And I also realized that the same reason why somebody might want to undergo MAiD, right? If they're losing some of their personality and their personhood through their neurological dysfunction, that might be a motivation for MAiD, but at the same time, that could also be an impediment to capacity for that MAiD decision. So I realized that we had a unique situation for our brain cancer patients where we don't really understand how best to assess capacity for them. It's unique among cancers, relatively unique among neurological conditions that are progressive. And so I reached out to our bioethicist at Princess Margaret and began a great collaboration with Jennifer Bell to work on this research project. Next slide. There we go. So a bit more background. Medical assistance in dying, or something by similar names, is legal in many jurisdictions around the world, including within Canada, obviously, since 2016. Just trying to advance the slide, and I'm struggling here. There we go. Within Canada, the United States, and certain states within Colombia, Switzerland, the Benelux countries, Australia. This is actually out of date, even though this is from, I believe, a couple of years ago. There's now more countries that have made MAiD legal. Next slide. Next slide. There we go. So when we talk about brain cancer, we're talking about both cancers that start in the brain, but also cancers that start elsewhere and go to the brain, as well as blood cancers that can involve the brain. The disease-related symptoms impact areas of the brain associated with both language, comprehension, memory. And so the neurological symptoms caused by brain cancer can absolutely affect decision-making capacity. Control and autonomy and desire to maintain those can be important drivers of MAiD requests. And so patient motivation for MAiD may be high in this brain cancer population, but as I said, because those same motivations can affect their capacity, there's unique barriers to access in this population. As a reminder, some of the pillars of decision-making capacity as outlined in this famous 1988 New England Journal article include the ability to communicate a choice, ability to understand relevant information, ability to appreciate the situation and its consequences, and ability to reason rationally. And brain lesions may weaken one or any of those pillars. I'll show you a diagram of some of the areas of the brain that can be especially affected to cause impaired decision-making capacity. One of the medical students that I'm working with, Claire Chang, thankfully put this figure together. And you can see the image on your left shows the left side of the brain, the prefrontal cortex highlighted in red, and Wernicke's area highlighted in blue. Those are both important areas for both language function and executive function, respectively. The figure on the right is a mid-sagittal specimen, and that shows what's called the circuit of Papes, which is a memory circuit of the brain, and impairments in any of those regions can lead to anterograde amnesia. And so executive dysfunction, receptive language dysfunction, anterograde amnesia, those are all problems that can contribute to incapacity. So the purpose of our mixed methods research study was to explore neuro-oncology clinicians' attitudes and perspectives on medical assistance in dying, including interpretations of mental capacity for patient MAiD eligibility. And the way that we organized things, we got RAB approval through UHN. We then sent a survey out to neuro-oncology clinicians, and then we interviewed some of the clinicians that answered the survey, plus some clinicians that didn't answer the survey, who we recruited elsewhere. I sent out emails to neuro-oncology societies, including the Society of Neuro-Oncology. There's a Canadian neuro-oncology mailing list. There's a neuropsychology mailing list. And that was all done through REDCap. I analyzed the data in R. Carolyn did a lot of the interviews. Jennifer Bell did quite a few of the interviews as well. They then analyzed the data together to look for common themes. And then there was an iterative thematic analysis to understand the data. So I will tell you about the surveys, and then later Carolyn will tell you about the interviews. Surveys were sent, as I said, to SNO members, to members of the European Association of Neuro-Oncology, to Canadian Neuro-Oncology, and also a neuropsychology group. I should note that there is overlap among these mailing lists, and some of the members of SNO might also be on EANO's mailing list and the CNO mailing list, etc. We only got completed surveys from 134 people, even though we did send out emails to a lot more. And there were 125 valid, non-duplicated surveys. I invited everybody who said that they would potentially be interested in an interview to an interview, and only 24 agreed. So of these 125 respondents, half of them were men, half of them were women. Most of them were neuro-oncologists, but you can see other professions were represented, including neurosurgeons, rad-oncs, nurse practitioners, physician assistants, psychologists, social workers, nurses. And most of them were adult neuro-oncologists, although some of them treated both children or adults and children. The MAiD years in practice was 10 to 14, or sorry, 20 plus, followed by 10 to 14. And on average, these we're seeing between 3 and 20 brain cancer patients per week. So these were clinicians with neuro-oncology expertise. Because we thought it was relevant to the question of whether somebody had moral objections to MAiD, we did ask about religion, and about half of them had no religion or no response, and the other half, or just slightly less, were Christian, and then other religions made up the minority. We got responses from all over the world, but the majority were from Canada, the United States, and Netherlands. You can see we had responses from just about every continent except for Antarctica, which was nice to see. We asked them whether MAiD was legal where they live, and in most of the cases, the answer was no. That fits with us seeing lots of responses from America, for example, where it's mostly illegal. And it's unusual that 2 of the participants did not know if MAiD was legal where they are. We asked whether they had ever participated in MAiD themselves, and most of them had not. We asked about moral objections to MAiD and gave them the option of saying that they're unsure. And most did not have objections, but 26% did, 17% were unsure. I then tried to figure out what we could do to predict whether somebody would have moral objections to MAiD, and I created a logistic regression model to be either yes, they hold objections, or no, we're unsure. and I fed in the variables that you see at the bottom. And this is what we found. The longer somebody was in practice as a neuro-oncology clinician, actually, the less likely they were to have moral objections to MAiD, which is interesting. Maybe they've acquired some wisdom with time. We also asked, we also saw that the country that they're from was relevant. So non-Canadian, non-Dutch, and non-American were more likely to have objections than Americans. And those who identified as Christian were more likely to have objections than those who identified as no religion. Interestingly, Catholicism itself did not specifically predict moral objections. Some of the cognitive functions that were thought to be important for decision-making capacity, we asked when they became worried that their patient with brain cancer no longer has the capacity to make a complex decision. And some of the topics that were brought up in this free text response were impaired cognition, language, memory, or the presence of confusion. If the patient had impaired insight or understanding or could not communicate reasons for choice, then they became concerned. Some of them mentioned that when there is disease progression, that flagged them to reconsider capacity. And then also where family brought up concern about their loved one, that could be a flag for incapacity. I then took them through some capacity scenarios. Each of them began with a 70-year-old woman with a glioblastoma diagnosed 1 year ago developed progressive disease on standard of care therapy. And each of the scenario ended with, she decides that she wants medical assistance in dying and you are her healthcare provider. Do you believe she will have the mental capacity to make this decision? And here's what we found. So in the first scenario, we said that the patient had aphasia and could only understand half of what others said to her. This was inspired by the case that I presented earlier. The second case, the family is concerned about the patient's new memory loss. The third scenario, the patient is quite fatigued, will spend 20 hours per day asleep, and will fall asleep in the middle of a conversation. And then in the last scenario, concern for personality change according to the family, where the patient is more impulsive, irrational, the family hardly recognizes her. So this is what we found. Really striking disagreement about whether these hypothetical patients have the decisional capacity to make a MAiD decision. So in the first scenario where the patient has 50% receptive language function, about 50% of participants thought that they were capable of making a MAiD decision. A little bit more likely to be deemed incapable in the amnesia scenario, a little bit less likely in the somnolence scenario, and the vast majority thought that the person in the personality change scenario was incapable. So I think the take home here is that there is no consensus, at least based on these brief scenarios, about who has the capacity to make a MAiD decision. I then did something where I added up the number of times that each participant said that somebody was capable in those four scenarios and tried to see what are the predictors of somebody being, of a participant thinking that the more hypothetical patients had capacity. And actually, advanced practice practitioners were more likely to deem somebody capable than neuro-oncologists. Canadians were more likely to deem somebody capable than Americans. It's kind of interesting, provocative. I then went through 5 more scenarios, and each of these was trying to get at specific clinical situations and reasonable foreseeability of death, really. So a blank-year-old man with a left hemispheric blank, diagnosed blank years ago, his ECOG performance status, this is a scale that goes from 0 through 5. 0 means excellent function, 5 is dead. Each scenario ends with, he decides that he wants medical assistance in dying, and you are the healthcare provider assessing him. If MAiD were legally available in your jurisdiction, would you support his decision to access MAiD? So would you support their decision to access MAiD? And these were the different scenarios. The first case, we looked at a 70-year-old with a glioblastoma diagnosed 6 months ago with poor performance status. The second scenario, the only difference was that the performance status was actually better, so reasonably independent at home. The third scenario is now a 20-year-old with a different tumor type, a slower growing tumor called an oligodendroglioma, diagnosed 6 months ago with good performance status. The fourth scenario, we're now back to a 70-year-old with a glioblastoma, now recently diagnosed, and performance status is poor. And the fifth scenario, it's now a 20-year-old with a glioblastoma, recently diagnosed, again, poor performance status. And you can see there's similarities among some of these scenarios, which allows for comparisons, which I'll show you soon. These are the findings. So if MAiD were legally available in your jurisdiction, would you support the patient's ability, or rather decision, to access it? And again, there's pretty striking disagreement here. Most respondents from all over the world thought that the first patient, 70-year-old with a progressive glioblastoma, 6 months out, poor performance status, ought to be eligible, and they would support their decision to access MAiD. Now, I'll show you the third scenario there. The young patient with recently, or rather relatively recently diagnosed oligodendroglioma with good performance status, most did not think this patient ought to get access to MAiD. And then there's some subtle differences in between. I'll get to that in a subsequent slide. I tried to see who is more likely to be approving of their patient's access to MAiD. Again, similar methodology to previous ordinal regression analysis. Canadians were more likely than Americans to support patients' MAiD access in these different scenarios. The non-Canadian, non-Dutch, non-Americans were less likely to support MAiD access than Americans. Advanced practice practitioners were more likely to support MAiD access than neuro-oncologists. And as I said, there's just subtle changes in each of these scenarios that allows for specific comparisons. And these are the three comparisons that I could do. So in one case here, we're comparing the performance status, ECOG 3 to ECOG 1. Are you more likely to support a MAiD decision in somebody who has poor performance status at home? That means, needing more care for, needing more help with care. This comparison here is looking at newly diagnosed compared to diagnosed 6 months ago. And then the last comparison was looking at a 70-year-old versus a 20-year-old, otherwise identical scenarios. And here's what I found. Nominal significance in all three comparisons. So looking at the proportion that supported each of the scenarios, time since progression, performance status, and age predicted whether somebody would support MAiD access for a given scenario. So around 26% of neuro-oncology clinicians have moral objections to MAiD. Executive function, complex attention, and language were voted as the most important cognitive. Clinician support of MAiD is high for older patients with progressive glioblastoma later in the disease course. Only half of clinicians are willing to support MAiD for patients at the time of initial cancer diagnosis. And clinician support of MAiD is low for young patients with low-grade glioma at the time of initial diagnosis. So this is a summary of those three comparisons that I just showed you. Next slide. Next slide. Oh, hold on. Where did we go? Let's go back here. Sorry. So I'll summarize again. Clinicians are divided on whether patients with moderate aphasia, amnesia, or somnolence tend to retain decision-making capacity for MAiD. Patients with clear personality change are not thought to retain decision-making capacity for MAiD. Time since diagnosis, performance status, and patient age all influence whether clinicians support a patient's MAiD request. So those are the results of the survey. We did, as I said, ask at the end of the survey whether the participants would be willing to undergo interviews, and we're grateful that 24 participants did undergo interviews. So I'll hand over the microphone now to Carolyn, who will take you through the qualitative study.
Thanks, Seth. Thanks to JCB for inviting us to do this presentation also. And as Seth has mentioned, I will be presenting the results from our qualitative study on neuro-oncology clinicians' perspectives on factors affecting their patients' access to medical assistance in dying. So this study explored neuro-oncology clinicians' perspectives on access and eligibility for MAiD for patients diagnosed with brain cancer. And as Seth had mentioned this a little earlier on, we did use a qualitative methodology guided by a feminist ethics relational framework. A purposive sampling approach was used to recruit participants from the group that Seth had for the initial study, who met the eligibility criteria. Semi-structured interviews were conducted and the themes were identified and reported using an interpretive descriptive approach. A total of 24 participants who worked in various capacities with neuro-oncology patients were included in the study. Most participants were from Canada and various states in the US, much like the first study. The participants were, 7 of the participants were directly involved in MAiD as assessors and or providers. 13 were non-supporting or non-participating supporters, and 4 were conscientious objectors. 9 participants were from jurisdictions where MAiD was illegal. So the study generated 6 main themes, which I will discuss in detail in the following slides. The first theme was on the perspectives on providing MAiD in the context of neuro-oncology. Most participants supported the availability of MAiD to their patients. Some were uncomfortable in being involved in MAiD due to personal, religious, and or professional values. As one participant shared, MAiD is hard because I feel like you are cutting life early, but I know the outcome will ultimately be the same. You have to be ready to accept death. I'm not there yet, but again, that's just my own personal bias. Participants expressed concerns that neuro-oncology patients are disadvantaged due to their unique disease process in the context of MAiD. As one participant shared, for many patients, as they become more and more disabled, they didn't want to be there anymore. The same trigger or changes in condition makes them ineligible to use MAiD. Interestingly, most participants believed that patients required a high threshold of decision-making capacity in order to consent for MAiD. As the participant in this quote states, I believe a MAiD decision requires a very high, maybe the highest threshold of capacity, because it is a decision that cannot be taken back. The second theme highlights some challenges participants experienced with the MAiD legislation in various jurisdictions. Some discuss the limitations, such as the small window of opportunity that these patients often have to access MAiD. As one participant shared, I've certainly witnessed a few of our patients who have pursued MAiD for far earlier than they probably would have wanted to because of their fear of capacity loss. In Canada, with the introduction of Bill C7, this may have sort of reduced somewhat. Some participants were concerned that the lack of clarity on their professional role with MAiD may have resulted in limiting the patient's access to MAiD. As one participant shared, we very much shied away from discussing the expected progression of disability that's going to take place. And unless we're making this information readily available, it's quite hard for people to make informed decisions. Others were concerned with the inconsistencies with the determination of reasonably foreseeable death criteria, specifically for this patient population. Participants reported experiencing conflicting personal and professional values and responsibilities. For example, some had challenges accepting patients' requests for MAiD when they were based on existential suffering. As one participant stated, if they're not suffering, they only want it because they want control. The patient just tells you, oh, I have existential suffering, but that's hard to objectively appreciate. I've been declining those. While they wanted to help other patients, some feared legal and professional ramifications of making errors. As this participant stated, I sometimes wonder, are we missing something? Should we be worried? And then I worry a little bit about the timing and how quickly they deteriorate. Family members' influences, especially when they were opposed to MAiD, further complicated MAiD requests. The fourth theme is determining decision-making capacity. And some of this was already touched on by Seth when he talked about the different symptoms that they may experience. And so similar to the findings from the first study, many participants indicated that neuro-oncology patients requested MAiD believe that they required extensive capacity assessments that were often not conducted or required for other treatment decisions. And this may be due to the challenges in determining decision-making capacity when they experience certain symptoms, specifically, for example, the symptoms that impacted communication, as in the case of receptive or expressive aphasia, and or the presence of personality changes or depression, etc. The next theme is about contextual influences on establishing eligibility. Participants found it challenging to accept MAiD requests from patients in certain contexts. For example, when the patients were younger, or if they had, or the extent of suffering that the patient was reporting was not measurable. However, some pointed out that in practice, assessing what was important to the patient and how they perceived quality of life was often neglected or lacking. As one participant shared, patients spoke up and said, "There's nothing in these assessment tools that asks me, what are your hopes for the future and what is important for you today?" Many participants were more comfortable offering disease-focused treatment options rather than supportive care. One participant shared the following when asked about offering alternative treatments. "That doesn't mean that we have to be value neutral. A physician should always provide some guidance as to which of these choices is likely to be in the patient's best interests." Alternatively, familiarity with patients and established relationships, as well as consistency of patients' requests for MAiD, facilitated patients' access for MAiD. The final theme discusses supporting patients and the healthcare team with access to MAiD. Some participants raised the need to advocate to improve the access to MAiD for neuro-oncology patients. Many suggested that neuro-oncology societies could partake in improving training and education on end-of-life care. Participants also suggested using a team approach to facilitate informed decision-making and patient-centered care, as one participant shared. Multidisciplinary team approach that includes bioethicists as well as professionals, whether they are medical or mental health care professionals, who could contribute to the evaluation. I think that would make it a lot easier for them to make decisions, and this is about MAiD eligibility. So our study identifies relational influences on neuro-oncology providers' impact on patients' access to MAiD, and this includes clinicians' comfort level with MAiD as an end-of-life option, their comfort level with having end-of-life discussions, their perceptions about quality of life, exploring and accepting suffering beyond what's physical, and using sometimes a paternalistic approach to care, which is used to maintain what they may perceive as is in the best interest of the patient, relationship with that they establish with their patients, as well as the support and resources that are available to these providers. So to reiterate, some potential for inequitable access would include delayed capacity assessments, professional beliefs that existential suffering is not a criteria for MAiD, as well as professional views about quality of life versus what the patient might view as quality of life, or their perceptions about quality of life for themselves, and assumptions regarding younger patients versus older, and as well as the treatments that have been trialed. So some of the recommendations we're offering are to improve training and resources that are directed at improving end-of-life conversations as well as care, advanced care planning and access to information about all available end-of-life options to the patients, increasing awareness about MAiD and the biases or practices that may unjustly influence patients' access to MAiD. As well as using a team approach to ensure a holistic approach to care that would, in turn improve patients' access to MAiD. So our study has some limitations. Our research design does not explicitly solicit input from MAiD providers, and it is unknown how widespread such perceptions and experiences may be. And we acknowledge that further research is required that includes patients as well as their families. And we would like to leave you with this touching blog about glioblastoma and MAiD, and in which a caregiver beautifully narrates the challenges she experiences with her husband's end-of-life journey through MAiD. She advocates for improved end-of-life care and suggests the following. Perhaps what should happen in our situation was once my husband was told he was going to die, practitioners should have asked him if he wanted to apply for MAiD. Thank you for joining us today, and we look forward to your questions and comments. Here are our references.
Wonderful. Thank you so much for that presentation, Caroline and Seth. That was wonderful. And I'm just looking to see if questions have come in. It does often take a couple of moments. I do want to let everyone know who is tuning in on YouTube that you can absolutely post questions via the YouTube chat. If, however, you aren't logged into YouTube and you do want to send in a question or a comment, or you want to do so anonymously, you can email your question or comment to jcb.ea@utoronto.ca. And I believe this information is in the chat within YouTube, so you can reference it there. So perhaps I'll start off by just asking a question that came to mind, and I'm not sure who would be most appropriate to answer it. And I do recognize some of my questions, they might expand beyond the scope of your specific research and maybe ask you to hypothesize to a certain extent. But Seth, I think it was during your section that you mentioned only half of clinicians are willing to support MAiD early in a patient's diagnosis or early in their brain cancer journey. And immediately when you mentioned this, I wondered why. Is it because of individual perceptions around quality of life? What might that be based on? And then Caroline, you mentioned that patients with brain cancer, they become, of course, increasingly disabled over time. So I was just wondering if you can maybe speak a little bit to that, whether it is because you've learned about that perspective in the interviews, or if you would hypothesize just based on the quantitative information.
Sure, I can answer your first question. So I'm going to speak as both a neuro-oncology clinician as well as a researcher here. Speaking as a clinician, when we see a patient with a new brain cancer diagnosis and tell them about their diagnosis, the patients are usually in a lot of shock, right? It's tons of information. It usually comes as a very big surprise to them. And it's a lot of information for them to take in. And so I don't really like when my patients are making rash decisions or big and sudden decisions when they're first finding out about their brain cancer diagnosis. There's also quite a bit of variability among brain tumors, right? So even glioblastomas, although the median survival is somewhere between 12 and 15 months, and that's even with therapy, there are patients who will survive 15, 20, 25 years. That's sort of the longest that I've seen. And that's the worst brain cancer, but there's also other brain cancers that have median survivals closer to 10 or 15 years. And so I think soon after diagnosis, it's nice to have a bit of a cooling off period where the patient just gets a sense or some time to understand their diagnosis and some expectations for the future. And if they still, reiterate a clear and consistent opinion that they would prefer to have MAiD, then I think it's reasonable to go ahead and pursue that.
Thank you so much for that. Oh, please, Carolyn.
Sorry, just to add to that, I'm wondering, from other studies that I've been a part of, it is a quick sort of trajectory sometimes, especially during that initial process of being diagnosed. And so, having access to information about what is available to the patients may improve or increase their accessibility for MAiD. But sometimes that window of opportunity is really small. So, that is interesting that only half of the participants were willing to talk about MAiD or bring that up or provide MAiD.
I mean, the window of opportunity is small for brain tumor patients, but that's a relative term. And I also think it's important not to rush into this decision, because often our patients will deteriorate over the course of months, not days. And so there is still a window of opportunity.
Thank you for that. A comment came in. I'm not sure if you want to respond in response to the comment, just saying that including palliative care teams in the early journey with neurocancers allows for open relationships and opportunities for an additional set of clinicians who support their journey. So I'm not sure if you have any thoughts in relation to that, if you did hear anything about collaboration amongst teams, amongst including palliative care teams, whether that is a supportive part of this process, or just have any general comment.
Sure. So I believe this came up in the interviews, and it certainly came up in some of the text responses in the survey, the importance of involving palliative care early. And I mean, I have a good relationship with my palliative care colleagues who I work with. I think they do a great service, and it is pivotal to maximize palliative care supports, so that if a patient is requesting MAiD, despite that, we understand that we've at least done our best to maximize the supportive care.
Thank you for sharing that experience. There's a couple of people who have written in, of course, saying thank you very much for this great presentation. Just a question around the sixth theme, Caroline. So improving access to MAiD for neuro-oncology patients is one of the, I guess, points that came out of that sixth theme. So in terms of, I guess, improving access to MAiD, was the idea, did you gather that the idea was a change in legislation being suggested? So for example, allowing for advance consent in order to ensure that people with, that neuro-oncology patients can consent in the future? Or was it thought that increasing clinicians' understanding of legislation and of MAiD so that more providers offer support is needed? So I guess just trying to gather a little bit more information around what is meant by improving access. Is it a change in legislation or increased education and trying to sway clinicians to be more supportive?
Thanks, Andrea. It just coincided that, at the end of our study that the legislation did change, but that wasn't something that we were sort of implying. But it was more about increasing access through some of the things that you've mentioned. For example, increasing awareness about the availability of MAiD, increasing healthcare providers or teams a comfort level with having end-of-life discussions, and as you talked about, including palliative care as well as MAiD, or giving patients the opportunities to talk about what may be important to them if their death is reasonably foreseeable. So some of those things were what the qualitative research was sort of pointing to, is that they often didn't have that opportunity, or as one of the participant quotes that I'd mentioned is that, talking about that trajectory towards death, or talking about or providing the patient that information was somewhat, I'm not saying this is universal, but sometimes it is lacking. And so opening up that conversation, or that an environment for the patients to share what is valuable to them, or what their quality of life might be, and allowing them to know that what options, end-of-life options they have available to them, and to help them make that informed decision about what their end of life might look like. I think that was what our study was more focused on, and it wasn't just Canada, so it was a global study, and so not everyone does have even the waiver of final consent that we do here. So I think that was what we were thinking.
Seth, did you want to add?
I see there's another question that I could maybe address,
Please.
Which was about the ordinal regression analysis in the survey that looked at predictors of somebody's willingness to deem somebody capable, right? So how many of the hypothetical patients were deemed capable by different professions? And what we found is that advanced practice practitioners were more likely to deem hypothetical patients capable than neuro-oncologists. And like I said, this is a sort of provocative result, and I don't really know how to interpret it. I mean, I have some theories. I'm not sure what the correct one is. Some of it might just be the type of people who go into APP professions as opposed to medicine. They might be slightly different. But the other possibility that I have to bring up is that neuro-oncologists tend to have extensive training in neuroanatomy and understanding of cognitive networks. And it's possible that we're a little bit more gun shy, a bit more afraid of deeming somebody capable if they have these neurological deficits. So that's where my bias is. I tend to be very careful deeming somebody capable for something like this if I think that they have impairment in receptive language function, anterograde memory function, for example, personality function, or if they're frankly, they can't stay awake enough for a conversation.
Thank you for responding to that. And just for those who may be tuning in, listening, so the question was really around this idea that advanced practice practitioners were more likely to deem someone capable than neuro-oncologists, and hypothesizing as to why. So thank you for sharing those insights, Seth. I'm seeing one question came in around, would you consider, and I know you noted this as one of the limitations, I believe, of your research, perhaps you could expand or speak about whether any research has been done around patients and care partners. So the question is, would you consider surveying and interviewing patients and their care partners to get their perspectives? So I'm not sure if you want to comment on that. It sounds like the answer might be yes, so that was noted as a limitation. Does any research like that exist already?
To my knowledge, nobody specifically looked at MAiD and brain tumors really before we did here. People who have systemic malignancies that have gone to the brain, those sorts of patients have been interviewed, I'm sure, but not in a systematic way. I think, as we mentioned, it's sort of outside the scope of this project and the grant that we were given for this project, but I'm absolutely interested in pursuing this in the future as part of a research career.
Thank you for that. And a question came in, and it seems like it's more around the MAiD legislation. I assume we can speak to, perhaps you can speak to perspectives or to legislations that do exist around the globe, but recognizing we're in Canada, perhaps it's focused here, I'm not sure. Just around the time frame of deciding when a patient can actually have MAiD. So the question is, how do you know that a patient's decision for MAiD isn't due to depression, for example? So yeah, this is legislation, this is very much MAiD focused, but wondering if you can offer some comments there around that, perhaps especially that latter piece, knowing that the decision is being made not on the basis of a depression.
I could try to answer that. That's a tough concept to grapple with, right? So we've now got to the point where we're saying that a desire to end your life does not necessarily imply that somebody is depressed, right? Whereas probably for a long time, the thinking was that a desire to end life implies depression. And so in order to figure out if somebody is depressed, if there's a suspicion of depression, I think it's important to rely on our colleagues, like psychologists and psychiatrists, to do a thorough assessment and try to understand the reasons for their motivation to end their life, and see whether mood dysfunction is a meaningful contributor to that. But the criteria for MAiD in Canada right now, as I understand them, that if somebody is significantly depressed and that's the driving motivation for their MAiD request, then they are not eligible for MAiD. There was also a question about the time frame on deciding when a patient can have MAiD. I don't think that there is a specific time frame. I mean, the old legislation talked about a 10 clear day waiting period, but ever since Bill C7, I believe that's been removed.
I can add to that. So if the time frame was what the question was sort of implying was the foreseeable death. If that was what was meant, it is subjective in terms of how a clinician may decide, a patient's foreseeability of death. And there is often, as Seth sort of the survey, the first study showed there might be discrepancies in how people determine that. But to answer the question about, the depression, yes, it needs to be addressed. But I'm going to talk about something that some of the participants in the qualitative piece talked about, and that was to differentiate between clinical depression and sort of somewhat reactive depression to being diagnosed with brain cancer, and so and that should be taken into consideration, and not to be assuming that everyone who might have symptoms of depression are clinically depressed. And as Seth said, if that was something that that was sort of thought about, that the patient was experiencing clinical depression, it needs to be consulted, and some other team members need to be included. However, there are instances where that might not be allowed because of the time frame that some of these patients might have or not have in order to access MAiD.
Thank you so much for those responses. And I'm saying a follow-up, just a comment, I like using the language like worries, wonders, and wishes. That provides an open opportunity for that layer of psychosocial support that opens up the thinking for the client and family, even if not needed right away. So I think that this is a follow-up to just the need to include palliative care teams, perhaps in a person's neuro-oncology journey, and perhaps how to frame challenging conversations and talking about worries, wonders, and wishes. So a few comments on that, of course, please feel free. There's just a question as well around this concept of existential distress, and whether a lot of participants did mention that being relevant to a desire for MAiD. And if so, did participants say that existential distress is what influences capacity or incapacity to consent for MAiD? So I guess just that relationship perhaps between existential distress and being able to support a person's capable decision to ask for MAiD.
So, sorry, I can talk to that in terms of the existential suffering. So it has to be taken into consideration when thinking about, or meeting the suffering criteria of eligibility for MAiD. And so patients could either have physical and or existential suffering. Our legislation does require, the provider assessing to explore what sort of treatments or what has been offered to the patient to sort of alleviate, ameliorate some of those symptoms that they may be experiencing, including, existential and physical suffering. But it does need to be taken into consideration when considering access to MAiD. But that may be separate from, the assessment for eligibility in terms of capacity to consent.
Also note that almost all of our patients have significant physical, in addition to cognitive dysfunction, related to the brain tumors that they have. And so it's very rare that it's only on the basis of existential suffering that somebody is applying for MAiD. Usually there's at least some degree of physical disability that's contributing to their concerns.
Thanks to both of you for chiming in to respond there. And another question came in just around the MAiD assessors. So one person does ask, who says they might have missed this, whether Seth, you are a MAiD assessor, but then the related question that just came in, says, given the identified clinical changes in brain cancer, so amnesia, aphasia, personality changes, would you agree that a clinician with a background in neuro-oncology is well positioned in conducting a MAiD assessment for this population where possible or available? Were there any suggestions or recommendations from your research that would support capacity building among neuro-oncologists in the role of a MAiD assessor?
Yeah, that's a good point. So I think a lot of our respondents in both the survey and the qualitative interviews agreed that the patient's primary oncologist should play an important role in determining the reasonable foreseeability of death where that's relevant. And also play an important role in determining the patient's capacity, because there is some content expertise necessary in understanding whether the patients with cognitive dysfunction are capable of making these important decisions. So many of them did think, like I do, that neuro-oncologists play a pivotal role and should play a pivotal role in capacity assessments for decisions like MAiD. Now, the question about supporting capacity building among neuro-oncologists and the role of a MAiD assessor, I don't exactly know what they mean by supporting capacity building, but many of them talk about doing workshops and teaching sessions to try to, in some way, standardize capacity assessment for MAiD in neuro-oncology.
Thank you for that. And of course, I'm not confident as well, based on my interpretation, that perfectly answered the supporting capacity building for neuro-oncologists in relation to assessors. And I know we have 2 minutes left, maybe just 1 or 2 more questions. So a question came in saying, would it mean that neurosurgeons would find advanced directives helpful? It would mean you could assess cognitive capacity, but also see that this was a request in advance. So I suppose this is really just getting to perhaps even responding to the last question, which is just given all of these identified clinical changes that may occur, would neurosurgeons potentially find advanced directives really helpful in terms of determining if a person is in fact capable of consenting?
I think I'm trying to understand this question. I guess part of the concern maybe is that after somebody undergoes brain surgery, they will lose some of their capacity. And so maybe before they undergo surgery, to try to, really understand what their desires and wants and wishes for the future are. I think that's nice in theory. The reality is most of our patients who undergo brain tumor surgery arrive in extremis. They're not well, and there's not usually much opportunity for advanced care planning in that setting. Also, many of our patients wake up from surgery better off than they were before the surgery itself. So our brain tumor resections tend to actually improve cognitive function rather than worsen it. So it's nice in theory, but in practice, I'm not sure that that's that practical, but I'd be open to discussing this in the future.
Thanks for that. I know it is 4:59, but there's just 2 little comments that I didn't get to, which is one of which is mentioning just a worry about the idea of categorizing people and perhaps hesitating to support people who want MAiD to apply or explore MAiD. And this person says they were under the impression it's everyone's right to apply, and then it's the assessors who would determine eligibility and capability. And so I wonder if this may, if maybe you could speak to some of the differing practices that exist globally, given that your research was very much global in nature, and perhaps that this comment is focused on the Canadian context. Maybe it's not the same everywhere.
Sorry, I can just to add to that though. Not everybody knows about MAiD, at least in the earlier days. It is becoming more, more publicized, so people know about it from what's in the social media, but there are still instances where people don't know that MAiD exists, even in Canada. And so sometimes it does need to be brought up by the healthcare team, or like they need to be provided information about what is available to them in terms of end-of-life care options.
Lovely. Thank you so much. All right. I'm glad that we got through all of the questions as well in perfect time. Just turned to 5:01. So with that, I suppose it is time to draw today's very full and thoughtful seminar to a close. So I have a couple of announcements to make before we formally thank our speakers. Our next seminar will take place on Wednesday, February the 9th, where Nicholas Leyland will be discussing medical negligence in gynecological surgery. And to sign up to receive our weekly seminar reminder emails, please feel free to email jcb.info@utoronto.ca. And as usual, CSB students who are enrolled in the CSB Student Seminar course, please remember to keep track of your attendance. And so on behalf of all of us, Seth and Caroline, thank you very much for your thought-provoking presentation and sharing your research findings with us. We appreciate it.
Thank you for having us.